how it's going.
Yeah, good. I've got the questions.
So it's
That's our last night here.
okay. So tell us how your last week has been, Dan.
It's been good. So it was hard just getting used to adjust. Well, we're just kind of winding down. So this week the obstetrician gynecologist was here. So she was here for 2 weeks. But we were away last week at Kungim, and then this week I had the opportunity to sit in with her clinics. Unfortunately, her big surgery day was the day we taught at the Catholic Health Service. But just sitting in with her was a good experience. I noticed there's a lot of infertility and there's a lot of pressure for women to have babies, particularly with men, and normally these are like the second or third wives of these men, and they feel that if they have a child, they'll be able to, the husband will keep them around, which apparently isn't always the case, so then they end up with children, without a father. So there was a lot of infertility that I saw, but not much here you can do in Kiunga. And then I saw a lot of menorrhagia, dysmenorrhea, some fibroids and those kind of things, but no surgeries really. And also did a lot of pap smears, so that's the first time I've done pap smears really. So I
How many did you do?
proficient in them. I don't know, I reckon I did 10 or 12.
Oh wow.
All up. So yeah, there's so lots of different cervixes. So yeah, that was a good experience because I haven't really had that much gynecology experience. And then just on that, I didn't see any deliveries whilst I was here. That's because during the days that I was here, there weren't any deliveries. Most of them were at night. And then I missed one today, but it was a placental abruption, so I saw the end of that case when I walked in there and then had to run away to go try to find some blood for the mum. But the baby was delivered and breathing and that. And then the other one that I was waiting for yesterday, she silently delivered on the floor last night without telling any of the midwives. And then only afterwards that she delivered did she call them. Yeah, and then I suppose one thing on the ward today, actually, I saw this girl. She was 14. Didn't look much older than 14. So she just delivered her second child, and she was she was in a arranged marriage, and it was interesting when this obstetrician was saying that they really need social workers here, particularly with a lot of mining and money and transient workers. There's a large vulnerable population, particularly in the villages, that need help working out their situations, and there's no mental health here at all, pretty much. But I think there's a lot of mental health issues that's just never addressed. So this girl, she was quite happy, but she was in grade 4. Here they don't really do, it's not how old you are, it's how you advance, and with the free education that came in last year, I talked to some of the teachers and they're saying a lot of students are deciding to keep themselves down a grade to make sure that they know it before going up to the next one. So it's not odd to see a 14-year-old in grade 4. So anyway, this was her second child. She had one last year that miscarried. That was a stillborn, and then she had this one. And what had happened in the family apparently was that the dad had passed away, leaving the mum and the children. And that's the most vulnerable part, is they were saying that it was an arranged marriage and they were threatening, to kill the children or something like that, not, harm them, if the mum didn't give away the daughter to this other family, who was an older man, and I think already had wives. So that was a bit unfortunate. It was a sad case, and you could tell amongst all the staff there as well, they truly felt sorry for her. And then I saw a few cases on the ward this week as well. But so I spent most of my time on gynecology, and then Tuesday, like Morello was saying, we went to the Catholic Health Service and taught. And then that's about my week, really. Yeah.
Okay, and tell us a little bit about the goodbye dinner that you just came from.
Oh yeah. Yes, so I had the goodbye dinner. It was a huge feast. I thought we had so much food that it was going to get eaten. but it was a never-ending line of hospital employees that came in, and some of their families as well. So they were rationed until the guys at the end just kind of ate whatever they could. And then the cake, there was a massive cake board as well that Graham organised with all our names on. It would have had to be like maybe 80 centimetres by, it was massive, and I was like, this will not get eaten. But that disappeared like within 10 minutes. Yeah, we were lucky to get a piece. So I don't think they eat cake very often. And there were, people taking multiple things. And I've noticed that a lot. When there's food, they don't hold back. They stock it up. So I think it's just a lot of people, it's a special occasion and they all eat a lot. Which you would as well, like we did that the other day. But yeah, and it was really nice saying goodbye to all the staff that we met, and as Mo said as well, there's certain ones that you bonded with. I think mostly mine would be the ones in outpatients, because that's where I spent 2 weeks in outpatients, and I really enjoyed that. And then also some on the general ward as well, because obviously you spend 2 weeks on the general ward when you do the surgery and anaesthetic kind of rotations. So I got some billums as well, which Murillo showed, and from different parts of it, and so it was really nice having it all explained by multiple people that, this one's from South Fly, this one's from North Fly, this one you can get wet, this one you have to put oil on, and yeah, so they, these people don't have much. The community health workers here at the moment are only getting 200 kina a fortnight, I think. So it's not much at all to be able to survive on, particularly when they've got kids. Yeah, then they're underpaid. That's why there's, I don't know if hopefully when future students come here to strike, they're meaning to get back paid. They're not getting paid that overtime or anything like that. So they went to go strike, but then they realised that they wrote to them they weren't actually in the union, so they couldn't strike and all this other stuff. So it's been an ongoing issue since September last year. So yeah, just sitting down and talking to some of the staff about that. A lot of them aren't happy, and they're really struggling. So then to have some of them, use their limited resources to then buy a billum for us as their, I think it's a traditional gift to give, was quite humbling, I suppose. And yeah, saying goodbye and doing all the clicks and that. So yeah, it was a bit sad towards the end as well. And made you realise that maybe a few more days would be good.
So overall, in regards to PNG, was there anything that jumped out and sort of surprised you, and anything that wasn't expected?
Yeah, the biggest thing was how friendly the people are, and everywhere, like the hospital, in the community, out at clinics. Everyone is just like, hello, or they say bye a lot, so they'll wave to you and say bye. And the way it was kind of told to us before we come, that it was dangerous, that you got to be looking over your shoulder all the time, just got to have that situational awareness, and I can understand why that was taught and that. But talking to a lot of the locals, Kiunga's not a concern for that. Obviously have some, personal safety, but a lot of them, even the locals here don't travel to Port Moresby or Mount Hagen, and they feel unsafe there, whereas Kiunga is definitely welcoming, safe. Ash didn't have any issues at any point. None of us had any issues. Everyone was nice. So that was the biggest surprise, the way everyone was so welcoming and liked to have a chat and that. So particularly up at Kundim, if you stood outside before you knew that someone was coming up to you to have a talk. With regards to the hospital, what surprised me is it's some things they have a lot of and some things they don't. They have, they don't have any gauze at some, like gauze, and they run out of certain things, but then some things they just got heaps of. I can't really think of one on the top of my head.
Amoxicillin.
Pardon?
Amoxicillin.
You got a lot of amoxicillin. But there's a bit of a contrast between some services they have and some they don't. Equipment, resources, that kind of stuff, and the way things are treated. One disease can be treated as as best it can, whereas some diseases, some illnesses, are just kind of brushed over. So that was another thing that kind of, and even talking to some of them, like, the obstetrician was shocked by the lack of medical care that's provided in Kulunga and the Western Province when they've got so much money. And I've noticed that another picking up from some of the more senior doctors and staff. I'm just chatting to them. If you ever noticed, I talked a lot about the institutional kind of stuff. They said there's a lot of money in the province, and the doctor that visited here, she said she can't understand why they don't have, curates in surgery and why everything's so run down in the hospital, when the province is one of the wealthiest ones. So that was interesting as well, just the maldistribution of funds.
Do you mind turning the fan off?
Really?
Yeah. I think it's affecting the sound. Sorry, I just couldn't be bothered getting up.
Yeah, I've had to put up with this for 6 weeks.
Now...
So also, just for those that are watching this, just think back and see how Mo's face has progressed over the last 6 weeks, and you make your decision as to whether he's put on any weight. Cause it's been a topic of this week, actually, on reflection. Some people noticed. I think it's the beard, but some people say otherwise. But yeah, that's just a side note.
Some people don't even believe the scales when I step on it. They think the scales are wrong. Anyway, just a separate question. Now, a patient passed away not so long ago. Can you comment on, our discussions that we were having about patients passing away, and I guess, what your thoughts are on that? You said at one point that you've seen more patients pass away here than in the 6 weeks you've been here than the whole 4 or 2 years of clinical.
Yeah. So we had a discussion about this last night. Basically, I have seen, from what I've been involved in, more patients die here than what I've seen, throughout my whole medical degree. It's not saying that those are preventable deaths, but I know there definitely are some deaths that could be prevented with different management. So it was difficult watching some of this and watching some of the, at home we're taught that sepsis is a huge thing. IV antibiotics straight away, fluids, oxygen and all that kind of stuff, regularly OBS and that kind of stuff. Whereas here, sepsis is treated on the ward just as any other patient, no rush around it. We'll give them some but we'll just give like the same dose that we do for, like a UTI that hasn't got out of, like maybe pyelonephritis, but it was just very different. And talking about it last night and that, Murillo talks, there's different ways to get there to the same, generally the same way, but one thing Graham noticed is the big difference is death is quite accepted here. And the way the doctors and the way the staff and that kind of treat, and generally, our staff's connection to a patient will also change how their treatment is. Whereas at home, I'm sure that happens, but not necessarily to that large degree. It's generally everyone's offered the same care. But the thing is, I think death's accepted, and for so long people have seen it, and that's what they're trained in, and that's what they're used to. Whereas, coming from, where our Australian healthcare system, we do whatever we can to prevent death. And not necessarily saying that's wrong, that's the right way to practice medicine, but it's just a total contrast, I think. And it was hard to get used to it, and it was difficult. I was at the point where I realised that I could never say anything because I'm only here for such a short time, and I think for any other students that come is you have to make that point. Like, I might have these discussions with Marilla later, or some of the other students, Graham, who's not involved in the care afterwards, but you don't talk about it in front of the staff that's there. You have to show respect for how they do it, particularly to the doctors and the staff. They do this every day, so for future students, have that in mind, and don't, in Australia we have that PACE or whatever it is, probe, alert, confront, and then emergency. That doesn't really work here. You can suggest and that, but I wouldn't recommend, particularly in front of a doctor. Make your recommendations, but don't continue to argue a point, I would say. So, the STEMI we picked up showed that, acted on straight away. But, sometimes recommended on changing a dose doesn't happen, or recommending on, trying to manipulate broken humerus so it actually
broken and dislocated.
broken. Yeah, well, yeah. So So realigning a broken humerus, we argued that point, and it was still just put in another cast, and that was made clear. So don't keep on going on about it. Point it out, see what they say, but you got to remember that they are the doctors and well experienced, and respect that. So yeah, if you have that, keep that in mind. But yeah, so as I say, is just realize that it's a total different world of medicine, and as I was saying, learning. You have to realize that there's limitations and there's different ways to do things here. They may not be the correct ways you do things at home, but that's how medicine and how care is provided here.
And sure, so as again going on that conversation we had, there were a few people that passed away, but there were also a few people that probably should have died.
Yeah.
But some freaking miracle, the low dose gent seemed to
Definitely. I've seen this a few times with two cases actually where they keep on putting off surgery because of a high blood pressure or because of lung issues or something like that. But the cause, we had this one girl with a pelvic abscess, septic, looked like death pretty much. They left her on the ward for a few days, documented getting worse, and then they're like, oh, we'll operate today, listen to the chest. Oh no, it doesn't sound very clear. We'll have to give her some more antibiotics and we'll operate tomorrow. Meanwhile, this girl, I reckon would be close. If she wasn't operated on in Australia, she'd probably be in ICU monitoring it. And she was just in the general ward. And we came home that day, we're like, she's going to die overnight. There won't be surgery tomorrow. And got there the next day in the morning. She was, she's still alive, took her into surgery. And a week later, she was up and walking around. And I suppose that's one good thing I was able to learn here is it's amazing what the human body can put up with. And maybe it's a credit to people of Papua New Guinea, what people put up with when they don't have a choice. But seeing people walking around with broken legs or malformations and simple things and chronic pain, things that would, I feel that I've never seen, but I feel that people wouldn't ever put up with. Here they just accept it and live with it. And I think that was the big difference as well, and a good insight to see is how, generally without intervention, people are quite strong.
Mm-hmm. Okay. The following is a two-part question, Dan. On reflecting back, what would you recommend to future students to learn before coming?
Yeah. I think overall the summary of what that was provided, I suppose it kind of prepared us for the learning that we would have to do. Whether we used it all or not, I don't know. We definitely used, near our resus, we taught that in the grand rounds. So maybe brushing up on how we do things in Australia, like grand rounds, CPR. We did history and examination presentations. So those things where, like at Rumganai, the Catholic Mission, Health Service, and grand rounds at the hospital, brush up on topics in Australia the way we do and learn the best practice, because that you get given situations to teach, and they're expecting you to teach what we do at home. But as with regards to then using that in the wards, it doesn't always work unless you've taught it beforehand. So there's that kind of so you just have to realise that the way we do things at home, it's not done like that here. And it's a constant challenge you'll have every day. And then I find that if I'm tired, hungry, or something like that, sometimes I just have to leave, would just leave hospital or get out of that ward, take a break and then come back, because it can be frustrating when you see you going around in circles or tests aren't coming up. And, I suppose our way of, what we're used to in hospital is you start to blame people, whereas here there's no blame. It's just like, okay, that's not done, we'll do that tomorrow. Kind of stuff, it's just accepted. No one's ever really personally blamed for anything. So antibiotics, learn chloramphenicol, learn what it interacts with. So drug interactions aren't that big here, so people don't really think about it. So I'm going to put a kid on, a small 3-year-old on like chloramphenicol and phenobarbital at the same time, which there's an interaction there. But because chloramphenicol isn't in any of our textbooks that we use, it was hard to find what the actual interaction was. Bring an AMH. I would recommend bringing an AMH or having MIMS or something for your own references, even though there's resources here. But if you can find an old version and leave it here, I'm sure that would be beneficial. Learning-wise, I think just come in with an open mind and be willing. You will learn more here than what you could at home. And just I don't know what they can really teach you more so. It was, just brush up on your ERTs and coughs and pediatrics if you're in outpatients. Know some of those common symptoms. Although they don't really have any middle ear infections here. I didn't see any.
Yeah.
But they have lots of like lower respiratory and upper respiratory infections that you see. Malaria, read that guide that they gave us, the Community Health Workers Guide on Malaria, and it tells you how to do the testing and the finger pricks and all that stuff. So that was a good read that I read when I was here. That's outpatients. Ward work, you just learn. Basically, you do all the tests and ordering and that kind of stuff. And then Obscon did do that much surgery. They bring good reference texts with you. You bring like the Oxford Handbook or something like that, because often you'll be asked to manage a patient. Or if you see a patient that they've got a disease, but you have no idea how to manage it, it's good then to you have the time to look up and then recommend that to the doctors. I suppose that's the other thing that I often found I was in, is you wouldn't have an issue finding a differential diagnosis, or you wouldn't have an issue with identifying what it could be. But what I found, the way we're taught at home is there's always, someone above us that tells us what to do, whereas here there's not that. It's you do whatever is there, kind of like you're at that next level thinking of putting the whole picture together, doing up the management, that's left to you to do. So for your own sake, I would recommend bringing some good reference texts.
I just want to chime in there. Just give you some beard shot, just because that's what I know you wanted. The two things I'd say: get a smartphone and download Medscape before you come, and you can download all the reference stuff. So you don't even need it, and you don't need to use internet. And just get some antibiotic apps or just whatever drug apps, just so that you can refer to them when you need, because I've been doing that a lot, at least just to make sure that I'm not giving too much. It still may not be the right dose that they give here, but it's something. And the other one was, if possible, maybe QRME or someone should buy an ophthalmoscope. Sorry, an otoscope, and actually, an otoscope, an ophthalmoscope, and what else? ENT related, even a tuning fork.
They do have them, yeah.
Do they?
Yeah, our patients have an otoscope and the ward has.
No, but they never work or whatever. Just get one. I'd really suggest getting one, because it's always never working or something's wrong. There was none in when I went on patrol, and it was just it was just ridiculous.
Yeah, I had a lot of pen torches and I just kind of left them throughout the hospital.
Yeah. And then I never found them when I went to look for them. They were gone.
Yeah, that happens.
Yeah.
And just bring like a random thing. I think equipment and just random pen torches were well received. We brought lots of gloves, but they have lots of gloves, so they probably don't need any more.
No, they don't.
They've got so many gloves.
Yeah.
Bring gauze. They never seem to have that. And we wrote a list down as we were going for what the hospital needs anyway. Cesarean kits, if you happen to have one. Bring that along. They need some. And also diagnostic dilatation and curettes and retractors.
Yeah, but that's not for students to bring, but that'll be... How else? What else would you recommend to other students to make the most of their time?
Yeah, so get involved, like, our biggest thing was getting involved with the local kids where we were. Make sure, well, we pushed it the whole time, and I'd really recommend you get yourself on one of the patrols. So we went to Kungim or Illawarra, one of those.
Illawarra.
Yeah. Get yourself on one of those, because that's where you see, like, we saw the traditional villages, Mosul, refugee camp 25 years on. Yeah, get yourself on one of those trips and push for it, and they'd love to have you on there. So that was really good. For me, trying it, when you're here, you can tend to not be at hospital. It's exhausting, the heat or the food or something. You get to lunchtime and you're just stuffed. So whether it's the frustration of having to think all the time, having to think or having to constantly justify things in your head why they're doing it, it is exhausting. So in the afternoon, when it starts to get a bit hotter as well, people tend to go home, and you notice then the staff also disappears, so then you just constantly feel like you're left alone. So towards the end, I kind of went home, but I think making the effort to go back later on in the afternoons is good, because you can see what's happening there, and you would have more time as well. So I didn't see all the different clinics and that, but yeah.
Okay, any other points you'd like to mention?
No, I recommend. Just have fun with it. Yeah, if you can, try some of the different foods down the market.
Bring some spices.
Bring spices, definitely. But we didn't even have any of the dried fish because we didn't know how to cook it. But ask the people in the hospital, and they love to tell you how to make their traditional dishes and all that stuff. So just a tip for those watching, maybe come future, is you boil the dried fish, then cook it in coconut milk. And it's not dried, sorry, it's smoked, and then apparently the smoke flavour goes throughout. It's meant to be amazing. But yeah, so try the local food, and if you don't know, ask the locals at the market, and they love it. They'll drag you around to get the best produce that's there, and we'll show you the different kinds of bananas and what's eating and what's not. Yeah, so do that. Try go out to one of the local with Ben. The outside trips out of hospital, which Graham's awesome at organising that, and we haven't mentioned him in any of our video diaries, but Graham definitely made our stay here awesome. Like, he made sure we were looked after. He tried to do whatever he could for us to make sure we had a great time.
Graham's the bomb.
Yeah. So yeah, I mean, he fitted in with our jokes and getting a few people sort of sense of humour. So it was really good going out at his for dinner and chocolates. But yeah, if you don't know anything, just ask. People don't really, one of the things they told us when they were training is you can't say anything stupid in Pidgin or offensive. So it's the same, you can't really ask any stupid questions. You could ask some offensive questions maybe, but I don't think you could ask many stupid questions. And if you do, they just laugh at you.
Okay. Yeah. I think you've been talking for an hour and a half, so probably...
Do you have any final tips for you, man?
Final tips from me.
Do you want to point the camera at you?
Get my beard in it. You're right. There's the beard, guys.
Would you recommend growing a beard?
I would 100% recommend growing a beard. It was very well received, and I think that I'll probably keep it for a little while. But just be aware, you might get called fat because it adds weight to your face, even though you haven't gained weight. What else can I say? Keep the peace with whoever you come here with, because at the end of the day, you don't really, you sort of, that's how it works. If you argue or get in fights or whatever, just put your tail between your legs and say you're sorry and just move on. Yeah. And grow a beard.
Do that.
No.